Here's Dr. Scott Edmonds.
Thank you. Good morning, everybody. I want to change it up a little bit now and talk about, rather than the specific treatments and procedures for glaucoma, what do we do when you've had these procedures and you have vision loss? Unfortunately, glaucoma is such a complex disease, as you've just heard, that in spite of best efforts, often the vision is compromised. Now, my name is Scott Edmonds, and I am part of a team here, co-anchored by my wife, Dr. Susan Edmonds, and my son, Dr. Ryan Edmonds. We run the low vision and contact lens service here at Wills on the 10th floor. And we see a lot of patients with advanced glaucoma. So I want to talk to you today a little bit about how we manage patients with advanced glaucoma and why what we do in low vision is different than what you might have in your regular eye doctor's office. I want to talk about three basic themes today. First is find the vision. Second is focus the vision. And third is fix the vision. So our job is the three F's: to find it, to focus it, and to fix it. Now, the first thing we do is how do we find it? Many times with advanced glaucoma, people can't see the big E on the eye chart. Now, if we can't see the big E, how do we know how much sight you do or don't have? Often in a quick exam room, the doctor wants to know whether you can count the fingers or see the motion or see the light. But often people with glaucoma can count the fingers, so we know there's vision there somewhere between counting some fingers and being able to see the big E. So in low vision, we use much larger numbers, and we also move the testing distance from 20 feet, the normal mirrored 20 feet that you look at the big E, we move you into 10 feet. So when we move you into 10 feet, that expands your visual field and you're able to see better. We start with this big number, and many patients with advanced glaucoma will still look out there and say, look, doc, no one's been able to see. I haven't seen numbers in 10 years with this eye. I don't know why you're trying to kid me. So I will do the famous trick and say, now, I want you to look down at my shoes. The doctor often stands out there beside the number and say, look at my shoes. And when the patient looks down at my shoes, their eye moves down, and suddenly they'll see the number flash by because there is vision there. And by distracting them from looking straight at it, we kind of start to look at the peripheral vision, and suddenly they go, wow, I had a vision of a 7, but now it's gone. I don't see it anymore, but I thought I saw a 7. And at some point, I get accused of being a magician or performing some type of sleight of hand, because this is their blind eye. They haven't seen the big E in years. But once I start to be able to identify that they can see that 7, and sometimes it's not my shoes, it's the wall to the right or the wall to the left or the ceiling, but somewhere we find the vision. And once I find it, we can now start to measure it. And we measure it by making the numbers smaller and smaller. Now, at this chart now, you see the letters are much smaller. This is what we call our pyramid of vision, because the letters are arranged like a pyramid, one on the top, one on the left, one on the right. People with glaucoma often have visual field loss, and often the visual field loss is such that they don't see what they're looking at, but they see something right below it or right above it. So if a patient looks at that chart and says 7-3, then I know that their top part of their vision is impaired, so they have field loss above. And people with glaucoma often consistently can only see the bottom of the pyramid as we go through the charts. Now, patients with macular degeneration, another common problem that we see in low vision, sometimes coexisting with glaucoma, those people tend to be random. On this chart, they'll see the 7. On the next chart, they'll see the number to the right or the number above. They tend to skip around. But people with glaucoma more consistently miss the same number. When I tell them, okay, you're seeing the 7 and 3, but there's a third number out there, try to look to the ceiling, and as they look up, all of a sudden, they'll see the 5. So we're starting to be able to quantify how much vision is there, and we keep making the chart smaller and smaller until we find the threshold of what their actual vision is. Now, we've found the vision. We've achieved our first task, which is to find the vision. Now, the next task is focus it. Now, when an eye doctor wants to focus your vision, he normally uses a gadget like this. This gadget is called a phoropter. The problem with the phoropter is each of the lens clicks are very close to each other. And when we had to hunt around to find your vision, when you put this machine up there, there's a good chance you can't even see the big 7. So we really can't use this instrument. It's too limiting in that you can't move behind the phoropter, and that the little clicks that the doctor make are too small for people with vision loss to be able to determine which lens was better. So in people with advanced glaucoma, we use the old-fashioned trial frame. It's hard to get these anymore because they were used. They stopped using them popularly when the phoropter was invented, probably in the 40s. But we still have these trial lens instruments. And when I put the trial lens on your face, you can move your head right, down, up, and left, and you can see my numbers. And that I need you to be able to see the number so I can bring it into focus. This is the part of the test where we do the famous which is better, 1 or 2. When the doctor is asking you 1 or 2, there's 3 major components of your refraction or of your focus that we measure. And choice number 1 is a little stronger than what's in the machine. Choice number 2 is a little weaker. We just want to know, do we go stronger or do we go weaker to try to better focus your vision? So there is not a right answer. Sometimes it's 1, sometimes it's 2, depending on the person and how their focus is. That question we need to know to be able to adjust the lenses. Now, in this machine, I can adjust them with my trial frame kit. I can make huge changes between 1 and 2. So if you're not sure, I can make a big difference between those choices so that you can help determine your prescription. Now here's an example, not what we do, but here's why low vision refractions are different. If I were to ask you which image is square, and we were to just look at the left-hand side of the picture, and there's 2 boxes there, which image is square, 1 or 2? Anybody tell me which one is the square one and which one is out of square? 1 is in square. Now, people with good vision can make that really fine determination that the choice 1 is the correct answer. That's the one that's more in square. If you have low vision and you're looking at this yellow side of the chart, you may be saying they both look square to me. I can't see which one is more square than the other because my vision is too limited to be able to do that. So people with low vision, we use what's called an exaggerated test. We make a big difference between 1 and 2. Most people now in the room can tell me which is more square, 1 or 2. Clearly, box 1 is more square. Box 2 is way out of square. So think about this using in terms of lens powers rather than squares. When we test you in low vision, we make a big differential so that you can, in spite of your reduced vision, can easily tell me which one is better. And so I know whether to make your prescription stronger or weaker to bring it into better focus. So this is how we do job 2 in low vision, exaggerate the tests using these different techniques to be able to bring that letter into clear focus. Now, once I got the letter focused, I often find that the number that you read on the chart, you can now go down much further because I've focused the letter. Initially, you were looking at the letter out of focus. Now that I retest you with the correct refraction in that machine, now I find that your number is considerably better. Now I'm going to use that number to calculate what we call magnification. So we use your best prescription, the combination of astigmatism and powers, and add magnification, and we put it into a strong pair of glasses to be able to create a magnifying system that has your exact focus. Now, when we use the magnification, it's very numerical. If your vision is only 20/40 and you need it to be 20/20, I need to make it twice as good, so I would use a 2x magnifier. It's very, very arithmetic. We use simple math to figure out how much magnification we need to get you to see your goal vision. The trick now, though, is the last F. So I can find it, I can focus it, but the problem is when you go to use that vision, you're going to use your natural habits of looking directly at the light, or directly where your eye thinks your brain thinks your eye should see correctly. People naturally learned a way to use their eye when it was normal. The brain doesn't understand that the eye is no longer normal, and the brain keeps directing the eye back to the place where it thinks the best vision would be. With advanced glaucoma, that place is not there, it's somewhere else. We found it through our special testing, but now how do I get you to go to the spot that we found and focused to be able to use it? So we found that if you repetitively recognize words and letters, that your eye and brain can learn a new pattern of the way your eye moves from letter to letter and word to word so that you can start to build words and build text in your mind. So this is a technique we call vision rehabilitation. It's teaching your eye to work in a different way than it normally works to be able to achieve your goal of reading or watching television or whatever task that we need to do. We sometimes need to put prisms in there to shift your vision away from the part that you think is normal. But this process is very similar to playing the piano. If you go to a piano and you don't play the piano and you go up there, you know you can make it make notes. You can plunk, 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 a note here, a note there. But how do you make it into a song? How do you make a bunch of random notes that you can easily plunk into a song? And the way we do that is you go to a teacher and they teach you a basic lesson, and then it is repeat, repeat, repeat. Repetition of a pattern of note after note turns random notes into a song. Same way we do this in low vision. We have you read a chart with those strong glasses that I showed you, letter by letter, moving from left to right, letter by letter. Initially, just like the early piano player, it's a lot of mistakes, it's a lot of skipping over and getting the wrong letter. But little by little, the brain and the eye start to align so that the brain moves the eye letter by letter, and you can achieve to read this chart. We start with big spacing at the top. we move to smaller spacing as we go down. We also have 4 levels. This is the largest level. We start with very large print, so it's easy initially to see the letter. We knew you could see that from our tests. But this repetitive pattern of reading it over and over again until the brain catches on that, oh, if I move the eye like this, I can read this word. Now we go from single letters to 2-letter words and 4-letter words. We have to keep the words random. Good readers can read a couple of words and figure out what the story is, and they know what the next word is. They guess the next word. They know sentence structure. They know content. And so good readers don't learn to use this technique unless we keep the words random because they figure out the content. Now, they also guess a lot, and often the story is suddenly totally different than what's actually there. But this process of giving you random words to go word by word until you get them correctly, until you build some speed, this is all called rehabilitation. Our program then moves you into a story. After you're finally able to identify words, now we have to put it all together in a meaningful framework so that you can read text. Now, we teach you how to read the text with this procedure. The key to this process is, first of all, focus the details on the healthy part of the eye. And in glaucoma, that could be almost anywhere. Everybody's optic nerve is damaged differently. We have to search around to find the area. So we focus the detail on the healthy part of the eye. We teach patients to use that best area to interpret their details, and we use repetition, 15 minutes, 3 times a day, like learning to play the piano over and over again. And then we provide appropriate glasses and magnification to meet their life goals. The next speaker is going to talk to you a little bit about adaptive aids, but we believe that once we take people through this process, we might have started out with them when they first came in, they were 2,400. We focused and refracted, and we got them down to 2,200. We did this test and taught them how to be able to see consistently. Now when they look at my charts, they can consistently hold a good spot. Maybe the vision's 20/60. So we took a person who was 2,400, who thought they were 2,400 based on the test, and actually trained him down to be 20/60. Well, at 20/60, there's a lot more things you can do. You don't need as much power in your adaptive aids. Your low vision devices are much easier once we get you to your best vision. The problem is the process of rehabilitation takes some time. It takes anywhere from probably 6 weeks at the short end to probably 6 months at the long end, and it is laborious. It's like learning to play the piano. It's why a lot of us don't play the piano, because it was too much work to do all the practicing to get good at it. But this is a life-altering procedure. When you learn how to do this, you're going to be able to do other tasks better, and that's what our goal is, to improve your quality of life. Now, again, we work as part of a team. We can't just do low vision and forget about glaucoma. It needs to be followed by your glaucoma doctor, because your pressure needs to be controlled, and all the other special features are learned about controlling the pressure and controlling the vision of the eye. That's all done on the medical surgical side, but we're going to work on your function, or being able to make the most of your system. As long as the other doctors can keep you stable, we can keep you functioning with these techniques. So those are my comments. If anybody has any questions, I'll be happy to answer them.